Thank you for joining us today for our Taking Control of Anaphylaxis webinar, part of our Know It, Treat It education initiative. This initiative is about demystifying anaphylaxis and giving everyone the confidence to know the signs and symptoms and how to treat it, helping to take the fear out of anaphylaxis and put control back in your hands. I am Ranjit Dangel, VP of Education Engagement at Food Allergy Canada, and today our guest speaker is Dr. Wade Watson. Before we get started, please note the following. This session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions upon registration. The format of today's session is a bit different than previous sessions as we are going to put forward several reaction scenarios. These have been based on the questions we've received from you. If you have additional questions or need clarification as we go through the session, please submit them in the question box throughout the webinar. We will try to address as many as we can at the end. And finally, this webinar will be recorded and shared on foodallergycanada.ca afterwards. A bit of background for today's session. For individuals and families managing food allergy, the fear of anaphylaxis is very real, especially when the journey of food allergy began with a severe reaction. That fear is heightened by knowing anaphylaxis can be life-threatening and by the challenge of recognizing symptoms in the moment. Is it anaphylaxis or just a mild reaction? Today, we'll explore how to understand and treat anaphylaxis with an interactive component to help build confidence in making that critical decision, guided by our expert, Dr. Wade Watson. Dr. Watson is a professor of pediatrics at Dalhousie University, head of the Division of Allergy at the IWK Health Center, and chair of the Specialty Committee Clinical Immunology and Allergy for the Royal College of Physicians and Surgeons of Canada. Dr. Watson is also a member of our Healthcare Advisory Board. Dr. Watson will begin with a brief overview of anaphylaxis, its signs, symptoms, and treatment, before presenting a series of scenarios where you'll test your knowledge through live polls on whether to treat with epinephrine. He'll then walk us through the expert perspective and reasoning behind each scenario. It's a great opportunity to test your knowledge and build confidence. Dr. Watson, thank you for taking time out of your busy schedule to be with us today and guiding us through this topic.
So what I'm going to do, as Ranjit had mentioned, we'll talk about taking control of anaphylaxis. So the learning objectives for this session is we'll review the signs and symptoms of anaphylaxis, by hopefully be able to recognize anaphylaxis, and more importantly, be confident in treating anaphylaxis and know when to use epinephrine. So we need to have a clear definition. So when we look at a definition of anaphylaxis, it's a severe allergic reaction, rapid in onset, and potentially life-threatening. So the symptoms generally involve 2 or more systems and requires prompt treatment with epinephrine. The World Allergy Organization in 2020 really tried to refine the definition to make it more practical and easy to follow. So I'm going to give you what their definitions were. So if we look at either you have an acute onset of an illness within minutes to several hours with involvement of the skin or mucosal tissue or bulk, so either generalized hives, itching or flushing, or swollen lips, tongue, uvula, plus one of the following, either airway or breathing compromise, circulation issues, so reduced blood pressure, or other symptoms such as severe gastrointestinal symptoms. So acute onset of skin or mucosal involvement plus another system involved. And it's the several hours that always confuses people. And basically, I work with a 2-hour window is the most likely time frame, but most symptoms happen within minutes, but symptoms can be delayed. The second definition is acute onset of hypertension or low blood pressure or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient. So even in the absence of any skin involvement. So if you're thinking about infants and children, so low blood pressure, adults would be that, or bronchospasm or wheezing, coughing, airway symptoms, or itchy throat, trouble swallowing, those sorts of things. So if we pick peanut, so if somebody eats peanut and faints, or if somebody eats peanut and has acute onset of wheezing or coughing, or their throat feels very tight and have trouble swallowing, that is anaphylaxis until proven otherwise. So we'll simplify it. So a sudden onset, so minutes to 2 hours. And again, either symptoms involving 2 or more body systems, skin, respiratory, gastrointestinal, or cardiovascular, or one symptom with known ingestion. And always remember, and this is important, that hives don't always appear during an anaphylactic reaction. The other thing that's important to understand is thresholds. There's typically, not everyone has the same threshold of responding to an allergen. So individuals will have their own threshold. So if there's a very small amount, they may not have a reaction, but there is a level of exposure that results in an allergic reaction. So not everybody has the same threshold. The other thing to remember is cofactors. So cofactors are things that change the threshold of a reaction and contribute to making a reaction more severe. So for some individuals, exposure to a food, and then you have a cofactor of exercise, heat, or exposure with an illness, so a virus, a flu-like illness may lower your threshold. Certain medications, such as non-steroidal anti-inflammatory drugs, alcohol can also change the threshold, fatigue, and uncontrolled asthma. So the most important thing is to remember that really fatalities are rare, but progression can be fast. So if you look at sort of the median time between exposure to either severe respiratory or cardiovascular symptoms with foods is about 30 minutes, venoms around 15 minutes, and a medication is around 5. The most important thing to remember is early treatment reduces the potential for either a biphasic reaction and hospital admissions. And really, it's important to remember that at home or in community treatment of that allergic reaction. And it's important to remember that not all anaphylaxis is life-threatening. So there can be mild symptoms which respond quickly to treatment. You can have severe wheezing or stridor, meaning you have trouble getting air into your lungs. And you can have more severe respiratory problems and low blood pressure or hypertension with loss of consciousness. And regardless of severity, all anaphylaxis is treated with epinephrine. But just to show in this graph that's there, I mean, if you look at mild versus moderate versus severe, most reactions are either mild to moderate. The important thing to remember is epinephrine is the treatment of choice. So if you look at the body systems, so breathing issues, epinephrine opens your airways. With regards to circulation, epinephrine raises the heart rate, raises the blood pressure, and increases heart contractions. So if you think about low blood pressure as part of anaphylaxis, you can see why epinephrine works. Most other thing to remember is in the immune system is epinephrine actually stops an ongoing reaction. So the cells in your body that release chemicals that cause the allergic reaction are called mast cells, and they release histamine, which triggers the breathing issues, blood pressure issues. And epinephrine is the most potent inhibitor of mast cell mediator release. So early use actually stops further release of mediators and helps to reduce the severity of the reaction. For the skin, it reduces the hives. And so as you can see with all of those things, but the important issues is your airway and breathing, airway, breathing, and circulation. An antihistamine only reduces hives. So if I say this 15 times, I will not apologize because it's important. Epinephrine is the most effective treatment for anaphylaxis. The onset of epinephrine is within a few minutes. So an antihistamine may take up to an hour to be effective, but it's only effective for reducing hives. That doesn't treat anaphylaxis. And oral corticosteroids, again, is not a treatment. It helps to stabilize things and reduce inflammation, but it's not going to be effective in that early treatment. So epinephrine, epinephrine, epinephrine. I just want to speak about Benadryl. So for all of you people who have a bottle of Benadryl or at home, I want you to go to your toolbox, and I would like you to get your hammer, and I'd like you to smash the bottle of Benadryl. Benadryl is a first-generation antihistamine. It is very sedating, causes drowsiness. I read this many years ago, that one dose of Benadryl has the same brain activity as a blood alcohol level of 0.1. So really, you're legally impaired. And that can certainly interfere with emergency department assessments, especially if you're assessing level of consciousness, which could be part of the anaphylaxis. So Benadryl is not something that we would recommend. I've worked very hard to get it out of our institution. It's still around for some hematology oncology issues where they require it, but it really should not be part of any treatment plan. So we're going to practice now, and we have a number of scenarios that we're going to discuss, and you're going to get to vote. And so Ranja's going to help me, I believe. So basically, I'm going to go through a decision tree. So when you have a situation, you need to ask yourself, is what I'm seeing anaphylaxis? Okay. So if the answer is yes, obviously you give epinephrine. But if you're uncertain, I mean, in that sort of situation, at that time, you give epinephrine. If the answer is no, you're going to watch closely. So if it's yes, epinephrine. Uncertain, epinephrine. No, watch closely. So here's case one. And so we have a 9-year-old with a peanut allergy who eats a cookie. So 10 minutes later, she develops hives on her arms, but otherwise is alert. She's breathing normally and speaking in full sentences. So is this anaphylaxis or just a mild allergic reaction? And what should you do next? So we're going to push out a poll now. So you have choices. If what you're seeing anaphylaxis is either yes, no, or uncertain.
Okay, Dr. Watson, I don't know if you saw the results of the poll, but I believe 50% of the people said no.
Okay. All right. So if you look at your decision tree, I mean, I would agree. This is no. I mean, you just have hives. So this individual is not having anaphylaxis. So it's important to watch, because if there's been a potential exposure to an allergen, it's important to watch for any progression of symptoms. And so you observe up to 2 hours after the suspected ingestion. And again, you're asking your questions. If there is any progression of symptoms, obviously you would give epinephrine. If there's no epinephrine is required. Only one body system in this situation is the skin, and skin symptoms alone do not equal anaphylaxis. We'll move on to case 2. So now we have a teenager with an egg allergy, eats a small bite of a cake at a party. He becomes flushed, complains his heart's racing, and feels like he can't catch his breath. So again, could this be a panic response, anaphylaxis, or could it be something else? So again, what should be done?
So we'll close and share the poll now so everybody can see the results. So it's yes is 51%, no is 11%, and uncertain is 38%.
And I understand that response. So we're going to move on. So again, if you look at your decision tree, is what you're seeing anaphylaxis. I mean, it really is, it's always hard, especially you have sort of throat symptoms, you have heart racing, you have, I mean, it's hard to know, is this anxiety or this is a reaction? But if there's a potential exposure, and there, especially if you have respiratory type symptoms, I would err on the side of giving epinephrine and then reevaluate. And the important thing about this, especially in this age group, anxiety and anaphylaxis can overlap. But if you have airway complaints after potential allergen exposure, it should be treated. And then if you feel like you need epinephrine, you use it. And I'm going to share, I like to share stories, but I remember a number of years ago, I had a young man with peanut allergy, and certainly had started having reactions where he would get throat tightness around peanut and peanut butter. But I became very suspicious when he thought he saw somebody eating a peanut butter sandwich and had the same symptom. So it's a matter of, is there an exposure? And again, if it's repeated and there's not any obvious ingestion, then it should be evaluated. But in the situation, you use epinephrine. So then we're going to talk about a 14-year-old with sesame allergy who had a snack, played soccer. So 30 minutes later, she suddenly feels dizzy, she collapses and is confused on waking. So could this be dehydration, low blood sugar, or anaphylaxis?
And now we'll share the results. So as you can see, it's 35% with a yes, 14% with no, and 52% uncertain.
So either did a good job creating these scenarios. So again, you ask yourself could this be anaphylaxis? Right. And in this sort of situation, you have somebody who has a sesame allergy who had a snack. So we don't know what the snack was. And then, with exercise, collapse. So the whole issue with the cofactor. So could there have been some sesame in the snack and you've got cardiovascular collapse after eating, or fainting, after eating a snack with somebody with a known allergy to sesame. So again, I would treat. So drop in blood pressure after potential allergen ingestion is a severe symptom and should be treated promptly. And then the whole issue with the cofactor may increase the risk for a severe reaction. So exercise may increase the allergen absorption, so that may contribute to the severity of this reaction. And then we have a 35-year-old. Now, I must preface this, I'm a pediatric allergist, so anybody over the age of 18 makes me nervous. So we have a 35-year-old with asthma and a tree nut allergy who starts coughing and wheezing after eating a dessert. So again, could this be asthma, anaphylaxis, or could it be both?
There you go. So yes, 63, no 5%, and uncertain 32%.
Okay. And again, so thinking about this, so you have somebody with asthma and with a tree nut allergy and has been eating. So, in this sort of situation, you've got respiratory symptoms with a known or probable ingestion. And so, yes, you would give epinephrine. And then again, you had some people who are uncertain. The uncertain part, if you're uncertain, you would use epinephrine. And again, certainly if you've got that exposure and respiratory symptoms, I would give epinephrine. And there really are no contraindications for the use of epinephrine. It is safe to use. And again, in a situation with asthma, it would be very unusual for somebody to have, while eating, all of a sudden have an acute asthma attack. So again, that should raise your suspicions. So now we have a child with a wheat allergy, has lunch and no symptoms, but 90 minutes later develops stomach cramps and starts coughing repeatedly. So could this still be anaphylaxis even though the reaction was delayed? So again, I'll have you think about that and vote.
So as you can see on the screen, so 87% with a yes, no 4%, and uncertain 9%.
So again, if we think about our decision tree, I would vote with the majority and say, yes, this is anaphylaxis, because you've got two body systems, you have a potential exposure. And although the symptoms are delayed, it's just a matter of remembering that symptoms can be delayed, and the individual issues can increase that. So yesterday, to give you an example, I had an 11-year-old who I was doing a food challenge, and we finished, and then all of a sudden, about 45 minutes after we finished, he disappeared into the bathroom, which was not a good sign. So he was vomiting. And so, I mean, things can be delayed. So always remember that if there's been that 2-hour window and this is potential exposure, you would treat. So again, even though reactions can happen within minutes, the time can vary up to several hours. But if symptoms appear, if you treat with epinephrine promptly, that's going to be the key to a successful management strategy. So now we have a 55-year-old man. Oh, I don't know if it's a man. So a 55-year-old person with milk allergy who has a snack, then faints while standing in line at the grocery store. On waking, he's pale, sweaty, and weak, but he has no rashes. Could he just have fainted, or could this be anaphylaxis?
So 51% with a yes, 11% with no, and 38% uncertain.
Okay. So again, I mean, is what you're seeing anaphylaxis. So the person has a milk allergy and has eaten something, and although standing in line, all of a sudden faints. That's a little bit worrisome. So, you know, I mean, even if you're uncertain, I would give epinephrine. And again, remember, if you have a potential exposure to somebody with a known allergy, and they have, you know, either acute breathing or respiratory problems or sudden cardiovascular collapse, then that's suspicious. So you always err on the side of treatment when fainting occurs after potential allergen exposure. Drop in blood pressure alone is a serious symptom. Okay, number 7. So we have a 20-year-old who has not been diagnosed with food allergy, eats a chocolate bar with hazelnuts, and starts feeling itchy in his mouth. So is this pollen food allergy syndrome, could this be anaphylaxis?
So yes is 39%, no at 22%, and uncertain at 39%. So yes and uncertain are tied here in this situation.
Okay. So again, your decision tree. So is what you're seeing anaphylaxis? To me, the answer is no. So you've got somebody who has eaten hazelnuts and got itching in their mouth. So if they have no other symptoms, then certainly it would be hard for us to call this anaphylaxis. So the important thing to remember here is there are, which I think drives families, adults, children, everybody crazy, is something called pollen food allergy syndrome. So what this is your primary allergy is not a food, it is a pollen. And there are storage proteins in pollens that will cross-react with various fruits and vegetables and tree nuts. So for example, somebody with a birch pollen allergy may react to hazelnuts with itching in their mouth, apples, raw apples, and so there's other foods as well. And on the Food Allergy Canada website, there's a lovely list of foods that cross-react with certain pollens. So the primary allergy is the pollen. So the way I explain it to families, it would be like, okay, if you were birch pollen allergic and you ate birch pollen, which nobody ever does, you would get itching in your mouth. These particular proteins are very acid labile, so as soon as they get into the stomach, they're broken down. The chances of having an anaphylactic reaction is probably around 1%, but it's important to have that diagnosed because the issue is that understanding what the risks are may be very helpful from a quality of life point of view for people suffering from this. So it is something called pollen food allergy syndrome, and it's something that if it is happening with anyone, it's important to see an allergist, have testing done, and have some explanation of the symptoms that are occurring. Okay, now we have a 6-month-old who has scrambled egg for the first time. Within minutes, has redness around her face. So is this just related to feeding, or is this anaphylaxis?
So we have 16% say yes, 46% say no, and 38% say uncertain.
Okay, so I'm just going to let you know that I have seen a large number of very young children with this problem recently. And the issue is is it anaphylaxis? So certainly with feeding, especially depending on the food, if it gets on their face, sometimes you'll get local irritation. And so, you know, if there is no other symptoms, then I would say this is no, and I would keep the food in the diet, because there's certainly good evidence that continued exposure to a food is less likely to be responsible for triggering a more severe reaction. And you know, certainly if if there's any swelling, you know, of the rash, or any swelling lips, mouth, or tongue, or anything else, then I think you need to be a bit more cautious. But if it's just redness around the mouth, I would not consider that an allergic reaction unless there's other symptoms that are involved. So if you maintain that food in the diet, once it's introduced, it's important to help prevent the development of food allergy. So always remember, even in babies, you're going to get behavior changes. So they become fussy, they may be hard to console, they may be crying, they may be refusing to feed, they may have hives, they may be irritable, they may be rubbing their face, there's some vomiting. But if the baby is happy but has redness around the mouth, to me, that is not a worrisome sign. So just to review, as again, one of the things that was indicated in the pre-survey is, how is anaphylaxis treated? I mean, issue is epinephrine is your treatment of choice. And the current in Canada, the only current device that is available is the EpiPen auto-injector. There's 2 doses, 0.15 for children up to about 25 to 30 kilograms, and the 0.3 milligrams for 30 kilograms and over. So you administer the epinephrine, and then it's important to activate emergency services. And the issue is not because you're using the epinephrine, it's just that there may be some monitoring. So are there any returns of allergic signs or symptoms that need to be treated? Certainly, if there's no improvement within 5 minutes, or symptoms improve and then worsen, you can use a second dose. Having said that, in real-world studies, the chances of requiring a second dose is probably less than 20%. But it is monitoring at a hospital for looking for any delayed or persistent symptoms is important. And so those are the steps that you use. So remember epinephrine first. Certainly, there is some questions about, does every episode of epinephrine, every time you use epinephrine, do you need to activate this? And certainly that's an issue that you should talk with your allergist, because there's maybe some criteria for monitoring at home, but these are the recommendations in general that we would give. So as I said, currently the 2 devices, or the 1 device is the EpiPen, and there's the EpiPen 0.3 milligrams, so 30 kilograms or more, and then EpiPen Junior. Now it says from 15 to 30, but your alternatives, if you're less than 15 kilograms, there really is no alternative. So the Canadian Society of Allergy recommends an EpiPen auto-injector, even for children less than 15 kilograms. There are vials of adrenaline available, but I think that trying to, in an emergency situation, even if you've been taught how to open a vial and draw up a smaller dose of epinephrine, I think that would lead to dosing mistakes, and we really would not recommend that. Certainly, I will bring up, there are other treatment options that are in the future. So there is an intranasal epinephrine that's undergoing review from Health Canada. So it's called neffy. So instead of an injection, it will be an intranasal spray, and certainly that has been licensed for use in the United States and is undergoing review in Health Canada. The only other thing that's coming is a sublingual, almost like a sublingual, I don't know if you call it tablet, but that can be under the tongue, that is still in early review as far as maybe something for the future. But what's currently available is the EpiPen. So some key takeaway messages is use epinephrine promptly if you think it's anaphylaxis. And epinephrine is the first line treatment, and you will not cause harm by using epinephrine. So I think that's time for questions. And we have 25 minutes for questions, so we should be exhausted by the end.
No,
so
that's great.
I need to end my slides.
Yeah, so just stop sharing. So thank you so much, Dr. Watson, for taking the time to walk us through these scenarios and offering your expertise. I invite you to turn on your webcam, and I will do the same. You just need to stop sharing this screen there. Oh, we can still see your screen, so just stop share at the bottom there. No problem. Perfect. Okay. So we're going to answer as many questions as we can that came up during registration and the presentation. The first one you already covered, which was on updates on alternative epinephrine devices. So Neffy and Anafilm, which is, I think, an under-the-tongue epinephrine film. That will be
I couldn't remember what it was called. I was thinking about I was thinking about my Lister mints that I use when I see 3-year-olds who tell me my breath smells.
Yes, that's what I think of too. So yeah, if approved, these devices would be definitely new options for treating anaphylaxis. So we did have questions on people who live in rural and remote locations. There were two questions. What to do if you're not close to a hospital, or how do you get someone by until one is reached? And then, can a person treat anaphylaxis with several EpiPens when there's no access to a hospital? How many doses of epinephrine can be given safely?
So the way that I have that question from a lot of parents, and I mean, some people are very uncomfortable. They would like to have more than 2 devices. They would like 3 devices. They would like 5 devices. So I tend to prescribe how many makes people comfortable. But more importantly, it's important to understand that using epinephrine early is the key to success. And so I usually say that you treat with the epinephrine. You're looking for improvement of symptoms or return of symptoms. So if symptoms, you initiate your emergency plan, but you would have a second device to use if symptoms return. And when I talk about symptoms return, it would be breathing issues, feeling lightheaded, that sort of thing. And as I mentioned before, probably only about 20% of reactions that occur outside a hospital require a second dose. But certainly it's important to have that second dose. Now, if highs return and there's no breathing issues or blood pressure issues, that is not something that I would treat with epinephrine. And so that would be important to remember. Certainly, if you've activated and you're waiting for emergency help, and again, you're more than 50, every 15 minutes, I think about you could use epinephrine. So, having a third dose at that time. After 3 doses, it's important to remember that, certainly what you're doing at home, you'll need extra help. So, it's important to remember that you initiate that emergency plan, but if somebody is so concerned that they're worried and they would like 5 EpiPens, I've given 5 EpiPens, but I haven't had anybody needing to use that over my experience.
Okay, well, thank you. That's really helpful. Our next question is on using the devices. So can any EpiPen device be used for children with food allergy if that child uses an EpiPen but they don't have it with them?
Well, again, it's important to remember the dosing, so certainly if you have nothing other than, if somebody is 15 kilograms or 20 kilograms and you have nothing but a 0.3 milligram epinephrine, and I would use it. I mean, you'd like theoretically something that is most appropriate for age. But there are stock epinephrine now in many schools in Canada, and that is for that emergency situation. So I think that if you, I mean, if somebody is having a severe reaction requiring epinephrine, and the only thing you have is an EpiPen 0.3, I mean, certainly you would use that. I mean, if it was a baby, I might be a little concerned about the dosing, but you can use any EpiPen, I think, in that situation.
Okay, great. And then kind of tagging on to that, what's the worst that could happen if you inject EpiPen or an epinephrine device and it was a false alarm, meaning it wasn't anaphylaxis?
Well, I've had colleagues that have actually done that when they're demonstrating, thinking that they have a trainer device in their hand and they have the real device. So, I mean, if you think about what epinephrine does, so let's all imagine that we're walking in the woods and all of a sudden a bear crosses our path, and you get that sudden shock, and your heart starts to race, and you feel very anxious, and you want to flee the situation. Your body is releasing adrenaline at that time for that fright and flight reaction. And I think in that sort of situation, thinking about epinephrine, so the increased heart rate, your blood pressure is probably going to go up a little bit, and you're probably going to feel very shaky, that sort of thing. Certainly, if you are 85 and had severe cardiac problems, you might be at slight risk for inducing worsening cardiac issues. But again, it's balancing out, is there a need for epinephrine? If you're uncertain, you would use it and then manage afterwards.
Okay. So now let's talk about antihistamines. There was many questions that came up on this topic throughout the talk as well as registration. So when would Claritin or Reactin or a similar over-the-counter antihistamine be suitable? Is there any time that an antihistamine can be the choice of action? And in what scenario would you use an antihistamine first?
Honestly, I wouldn't use it. And I mean, I've been doing this now since 1986. So I remember a situation where two very intelligent people, I think two physicians, and they needed a plan for the school. And so basically, if the child had an exposure, had 1 to 5 hives, they would use an antihistamine. But anyway, over 5, they would use the epinephrine. And my question was, who's counting the hives? So I mean, if you're having skin symptoms, either yourself or your child's going to be uncomfortable. But what you really want to do is monitor, do they have any other symptoms that requires epinephrine? An antihistamine will not stop anaphylaxis. It will make you slightly less itchy. But if a severe allergic reaction is happening, it's probably not going to be extremely effective. So it's a matter of monitoring. And certainly if there seems to be no progression of symptoms and they're itchy and uncomfortable, as long as you could use a non-sedating antihistamine, but you're monitoring still, I would probably give that 15 minutes to see what else is going on. But I just worry that individuals will use the antihistamine and then stop monitoring.
Mm-hmm.
So I can think of no situation where an antihistamine would be first line.
Okay. People still have questions about Benadryl. So
Okay.
will using Benadryl prior to giving the EpiPen interfere with one another? And when antihistamines like Benadryl are taken, do they mask symptoms of anaphylaxis? We hear that one a lot.
So they won't mask symptoms, except that they may enhance potential. So as I said, a dose of Benadryl can have the same effect as a blood alcohol level of 0.1. So decreased level of consciousness is and being woozy, unsteady on your feet, especially in a child, may mimic sort of like low blood pressure type issues. So again, Benadryl is the worst antihistamine on the market. The Canadian Society of Allergy was trying to get it have it behind the counter at the pharmacist, so you had to ask for it, and then require some education about non-sedating antihistamines. It is not, I mean, it is not something that should be part of a treatment plan. And antihistamines are only going to relieve itch, but are not going to do anything else. And again, masking itching, certainly not going to affect your breathing. It's not going to affect your blood pressure. So it really is not even first line.
Okay, thank you.
Is that clear enough for everyone?
I know, let's hope. No Benadryl, no
Correct.
antihistamines.
Yes.
Moving on to symptoms. So a few questions that came up during the session. What is the difference between anaphylaxis and anaphylactic shock?
It's all the same.
Mm-hmm.
It's exactly the same. Shock is that, I suppose shock means that you have impact on your blood pressure, but so that's anaphylaxis, but also severe respiratory difficulties after a known exposure is anaphylaxis. So I don't know. I don't use, I guess I've abandoned anaphylactic shock in my own terminology, because anaphylaxis to me is you have those broad definitions. But if somebody develops shock after exposure to a known allergen, that's anaphylaxis. You could call it anaphylactic shock. It's still anaphylaxis.
Okay. And if someone says their throat is itchy after a consumption of an allergen, am I correct in understanding that an antihistamine is not the appropriate treatment as it only treats hives? So that was a clarifying question that came in. So
Well, again, so my issue is if somebody has an itchy throat after exposure to an allergen, is this something new versus something that they've been exposed before? So let's say, if somebody's a peanut allergen, actually has peanut and has an itchy throat, I would be much more concerned about monitoring for presence of other symptoms. Um, Somebody with pollen food allergy syndrome, certainly the itching may be part of that. But again, the question is, you're monitoring if you have other symptoms. If there's no presence of other symptoms and it's still itchy after 15 to 30 minutes, so okay, you can use a non-sedating antihistamine, but you're still watching. Remember that 2-hour window is the thing that you're thinking about. So I'm always cautious in those situations, because I don't want people to say, okay, I've treated this, now I don't have to pay attention. And so that's my thing. But if it's more for comfort, and as long as you're monitoring for the presence of other symptoms, it's not going to mask anymore. It's not going to mask any of the respiratory symptoms. It's not going to mask any symptoms of fainting or vomiting, that sort of thing.
okay. How can you tell the difference between the sensation of something very spicy and an allergic reaction?
Well, again, to me, most people, when they complain of allergy, it's more itch, it's more maybe a lump in the back of the throat versus burning. Certainly something very spicy. And again, it's more itch. I think it's more itch versus burn to me. And again, it depends what you're eating. If you're eating a peanut butter sandwich and your mouth feels spicy, I'd be a little more worried than if you're eating something very spicy and your mouth burning in your mouth. So again, it's also depending on what you're eating as well.
Okay. What is the most commonly missed symptom of anaphylaxis?
Um, Denial. So, I don't mean that well, I do mean, it's really, people are very good at denying symptoms. So the issue is, you have to think about it. Have you eaten something that's potentially that you're allergic to? Are you having symptoms? Are you having trouble swallowing? Are you having difficulty with a lump in the back of your throat? Are you getting itchy? Those sorts of things. So most people tend to try to explain away symptoms, and it's a matter of, I don't think there's one particular thing, but it's just a matter of recognizing the symptoms you're having and are they potentially allergic.
Okay. Um, What do you do during delayed anaphylaxis? I know we had that scenario that talked about delayed anaphylaxis, but this was more a question on how to handle doctors that don't know about delayed anaphylaxis and what in this case, the person wrote, what my doctor thinks is anaphylaxis is different than the hospital. What do I tell the emergency department?
So this is where you advocate for yourself. I am allergic to X. I am having delayed symptoms, which is part of my allergic reaction. And if you've treated yourself with epinephrine, I have treated myself with anaphylaxis. In my situation, these symptoms can be delayed. And it's important that I be here for monitoring. Because the thing that drives me crazy is when the emergency department says, oh, you didn't need to come here, you didn't need to be here. And the issue is that undermines people's sense of confidence about recognizing and treating their symptoms. The person in the emergency room sees everybody with all kinds of reactions, and everybody is going to be different. So I think advocating and being very clear, I am allergic to X. These are the symptoms I'm having. I have treated myself and I'm worried or I'm having delayed symptoms, and it's a matter of just repeating those. Okay.
Okay.
Can I
Just
just
to
share
clarify,
something?
yes,
I
of course.
I I do food challenges quite frequently, and sometimes I have severe reactions. And I'm unfortunately I had an individual who needed to who go to the emergency department, and not only required epinephrine, but anyway, the emergency person said nobody has severe reactions like this. They always come in and have one dose of epinephrine. This is not how anaphylaxis occurs. And I said, this is anaphylaxis and it needs to be recognized and treated. So it is, people have different concepts, but I think it's important that you have a simple and straightforward message, and no one should make you feel that you shouldn't be there because you're advocating and these are the instructions and you do that because that's you are advocating for yourself and ensuring things are safe and you're being monitored.
Yeah, no, that's great. And we do hear that question come up a lot because there's seems to be confusion at emergency at times. So I think it is really important, that advocacy message. There's a question that came in for some clarification. So you mentioned approximately 20% of reactions may need a second dose. What typically is the reason for needing this second dose?
Well, again, it's going to be either return of breathing issues or blood pressure issues. So those are the things. So, you treat the you're treating, and again, if you think about percentages, so probably I'm going to say 75-80% is going to be respiratory type symptoms, and 25% is that sort of the ratio between breathing and fainting, feeling lightheaded. So it'd be a matter of what the symptoms have returned. And again, if you've got trouble breathing and you're coughing and you're wheezing, you use the epinephrine and it improves, but then all of a sudden those things are coming back, those are the things that you would use it for. What concerns me, and again, if I keep on harping on a few things, is that I've had emergency departments and, will treat hives. Somebody has just hives and no other symptoms, and they get 2 or 3 doses of epinephrine because the hives return. But epinephrine's not a treatment for hives, and hives are not anaphylaxis. So it's thinking about what are the severe symptoms. So if it's breathing, so cough, wheezing, shortness of breath. If you've got upper airway obstruction, stridor, so you can't having trouble getting air into your lungs, and then feeling lightheaded, feeling faint, those sorts of things. So those would be the 2 things that would return and require a second dose of epinephrine.
Okay, and then another clarifying question. If you administer epinephrine and symptoms are resolving, should you still proceed to the ER for assessment?
Well, that is the current recommendations, and it's the issue is it's for monitoring. So again, there's certainly a movement afoot. Are there situations where the anaphylaxis can be managed at home. And this certainly came up during the COVID pandemic, because, it's a dangerous going to emergency department in the middle of an epidemic. So those are discussions and decisions that you make with your allergist and have a discussion. That's a shared decision making. My recommendation is, even if the symptoms are improving, monitoring is important, and you go for monitoring. And again, but if it's an issue, that's something you would discuss with your allergist, and there would be a strict set of rules about when it would be appropriate not to go. But I would say the general recommendation is going to be monitored.
Okay, and then we just had a question come in right now about if it's hives only, but what about if it's full body hives or welts, like an extreme amount of hives?
So again, now it's a good question, because then I mean, to me, it's uncertain what's going to happen next, right? So if somebody has a known exposure to an allergen and all of a sudden they are looking like a lobster from head to foot, swallowing lips, mouth, or tongue, and it looks like things are progressing, I don't think there would be anything, I would encourage the use of epinephrine, because you don't know what's going to happen next. And then hindsight's always 2020. I mean, when we're talking about just outside symptoms, I mean, if it's a few hives or even, then it's a matter of important to monitoring. But if somebody is really having a generalized flush and they're really uncomfortable and they're in having anxiety, and because they're worried about, then you'd use the epinephrine. That would be appropriate.
Okay. And then the next two questions are kind of a little bit of a recap of the two scenarios that we covered. One is on how do you tell the difference between when you're having an allergic reaction and an anxiety attack?
So again, it's difficult. I mean, certainly objective symptoms, hives, swelling, those sorts of things, that does not happen. I mean, well, let me rephrase that. Somebody can get very anxious and get hives. I mean, certainly that does happen. But I guess the issue is, first of all, is there a known or potential exposure? So that will be number one. So if the answer is yes, so then what kind of symptoms are I having? So if I've eaten peanut and I'm worried that I'm having a reaction, sometimes you may feel like your heart's racing because you're anxious. You may feel you have trouble breathing. So you have some uncertainty, then I would use epinephrine. The issue comes down to is I've had situations where I've had an individual use 3 to 5 doses of epinephrine in a single week because of worry about potential reactions to foods, and that would raise my suspicions that maybe we're not dealing with an allergy. There may be some other issues that are involved, and certainly the most common I've had many people with either acute or chronic hives. And because sometimes, they get the hives, they get anxious, they get a little tightness in the throat, so it's misinterpreted. But, certainly recurrent anaphylaxis is extraordinarily rare. So in that sort of situation, it would mean, getting an evaluation by someone who's qualified to make a diagnosis.
Okay, if you're okay for time, Dr. Watson, we're going to go a few minutes over just because
Sure.
there are still a bunch of questions that are coming through. And to go with the other question on anxiety, again, how do you distinguish between anaphylaxis and an asthma flare-up?
Well, again, it's that the issue is that exposure. Okay. So an asthma flare-up. So if we think about our two definitions, so our two definitions, either you have skin plus another body system involved versus a single system but a known exposure. So if somebody has a cold and wakes up in the morning and starts having coughing and wheezing and there's no exposure to an allergen, then I would think that's asthma. If you are sitting on a bus and you haven't eaten in the previous 2 hours, or you've eaten your own food and you know that you haven't had an exposure and you start coughing and wheezing, then that's probably asthma. So the issue is there been exposure? Okay.
Mhm.
Now, a lot of people worry about, and again, my young man that I mentioned who was having issues with anxiety when he would actually he saw somebody eating a peanut butter sandwich and started having tightness in his throat and feeling lightheaded. I mean, certainly airborne, at least airborne from a peanut, that sort of thing, very, very unlikely to trigger a reaction. I mean, certainly fish frying, if you're fish allergic and you're in a kitchen where fish is frying, you can inhale the particles and it can have some cough and wheezing, but certainly it's that exposure component that you need to be thinking about.
Okay. This question's on biphasic that just came in. So, how long after inactivity after having a reaction can you assume that you're not in the danger zone anymore?
So just clarify, you're doing an activity?
So, how long after inactivity of a reaction? So, after you've had a reaction, it's under control, it's been treated,
Right.
there's that you can feel that you're safe, that you're no longer on alert
Oh,
to
I see
having a
what you're
biphasic.
saying. Okay, so I mean, typically, I mean, it's a matter, we should say 4 to 6 hours. I would think on average, most monitoring occurs for 4 hours. I would say if you're fine after 6 hours, the chances of having any other delay type symptoms would be very unusual.
Okay. Oh, sorry, we're going to say something else?
Well, the only thing I was thinking of, there are some individuals have food and exercise combined, food associated exercise induced anaphylaxis. So they can eat the food and not have any trouble, but if they exercise, uh, within 4 hours of eating the food, they can have a reaction. But that's a different type of syndrome, and that's something
Mm-hmm.
that people should be talking to their allergist about. But
Mm-hmm.
what I mean, if you're more than 6 hours, there's the chance of you having any delayed type reactions after that is very remote.
Okay. And then the last question is how to identify anaphylaxis versus illness, like stomach flu, while also just having a dose for oral immunotherapy. And maybe I don't know if you want to just quickly explain what oral immunotherapy is for people who might not know.
So for especially in young children less than 3, there's some increasing evidence that with a new diagnosis, with specific foods, tree nuts, peanuts, there are some allergists who are doing oral immunotherapy with starting very small doses on a regular basis and have a protocol increasing that dose over 20 to 40 weeks. And what you're trying to do is make the body less responsive with regards to accidental exposure and certainly looking at can you turn off this process. So the issue is that these are some of these things need to be talked with. So if that is something that's happening with you and your allergist, you need to be discussing those things as to what do you do. If you have either you have an illness and do you continue your oral immunotherapy because flu-like illnesses may increase your risk of having a reaction. So certainly that's something to you should be talking about that, what you're going to do in advance. But certainly if somebody has a flu and they're having stomach issues, that sort of thing, but there's usually that prodrome, other people are ill, and there's it's a progression of symptoms. And again, is it symptoms within that exposure window if you're undergoing immunotherapy? And if that's occurring, then that should be taken seriously. But again, that's a discussion that should be happening with your allergist. What do I do if my child has a flu-like illness? What do I do with regards to dosing? How do I proceed?
Okay, perfect. Well, thank you. Thank you for going a little bit of overtime here. Thank you for sharing your expertise and helping us build confidence in recognizing and managing anaphylaxis. So I'm going to close up the webinar with a few last slides. So thank you, Dr. Watson. We can take off our cameras now. So following this session, you will get a short survey through GoToWebinar that asks for your thoughts about today's webinar. Please take a moment to do the survey. It helps to inform our educational programming and advocacy efforts. Since this session focused mainly on the signs and symptoms of anaphylaxis, you can explore more resources at foodallergycanada.ca/anaphylaxis resources, including how to use epinephrine devices and overcoming treatment barriers through our webinars and Facebook Live events. Also, don't miss the video, What is Anaphylaxis, with Dr. Philippe Begel. That video clearly shows why prompt treatment with epinephrine leads to the best outcomes. It's really, truly a true light bulb moment for so many. You can also download our one-page sheets on epinephrine signs and symptoms and the 5 emergency steps that you saw there earlier with Dr. Watson. It's now back to school time. The school year has just started, and our back to school tips and resources are available to you all year long. So visit foodallergycanada.ca/back-to-school, where you'll find tips through our food allergy hacks and resources, including videos and tip sheets. October starts next week, and so does our Shine a Teal Light Halloween campaign, which is all about increasing public awareness of food allergy and ensuring it's an inclusive holiday for all. Stay tuned for more, where you'll get access to posters that you can put on your front door, tips, and the chance to purchase glow-in-the-dark bracelets. They are perfect to give out to trick-or-treaters. Today's webinar was supported by the Schroeder Foundation, the Peanut Bureau of Canada, EpiPen, and made possible from the donations of viewers like you. Thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share with others who may benefit from this content. This now concludes the webinar.